How do acute myeloid leukemia subtypes differ? Imagine trying to understand a complex puzzle where each piece is unique. That's what doctors do when they classify acute myeloid leukemia, or AML. It's not just one disease but a group of related conditions, each with its own characteristics. To figure out the best treatment and predict outcomes, they look at specific features of the abnormal blood cells. Two main systems help with this: the French-American-British system and the World Health Organization classification. The French-American-British system, developed in the 1970s, sorts AML into eight subtypes labeled M0 through M7. These are based on how mature the leukemia cells are and what type of myeloid cell they resemble. For example, M0 is undifferentiated leukemia, meaning the cells look very immature and show minimal signs of development. M1 is also immature but slightly more developed. M2 shows some maturation, with cells starting to look more like normal blood cells. M3 is a special subtype called acute promyelocytic leukemia, which has unique features and often responds well to specific treatments. M4 involves both myeloid and monocytic cells, while M4 eosinophilia, or MFA, has increased eosinophils, a type of white blood cell. M5 mainly affects monocytes, M6 involves red blood cell precursors, and M7 targets mucocorocyte precursors, which are involved in platelet production. On the other hand, the World Health Organization system, updated in recent years, focuses more on the genetic and chromosomal changes inside the leukemia cells. It groups AML into categories based on specific genetic abnormalities, such as translocations or mutations. For example, AML with recurrent genetic abnormalities includes cases with particular chromosomal changes like TA, UT, 21, or UNV, SUXTUN, which are linked to better or worse outcomes. There are also categories for AML that develops from previous blood disorders like myelodysplastic syndromes, or after exposure to certain treatments or environmental toxins. Some cases are classified as not otherwise specified, which includes subtypes that don't fit into the other groups, like AML with minimal differentiation or erythroid leukemia. There are also rare forms like AML that forms solid tumors outside the bone marrow, called myeloid sarcoma, or AML associated with Down syndrome. The key differences between these subtypes come down to what type of blood cell is affected, how mature the cells are, and the genetic features present. Some subtypes involve immature cells that haven't developed much, while others show more mature features. The genetic and chromosomal abnormalities help doctors predict how the disease might behave and how it might respond to treatment. For example, certain mutations can mean a better chance of remission, while others suggest a more aggressive disease course. Knowing whether the leukemia developed spontaneously or after previous treatment also influences the approach. Understanding these differences is crucial because it guides treatment decisions. Some subtypes respond well to standard chemotherapy, while others, like acute promyelocytic leukemia, benefit from targeted therapies that specifically address their genetic makeup. Accurate classification helps doctors estimate the risk of relapse and plan the most effective treatment strategies. It's important to remember that each person's leukemia is unique, and ongoing research continues to refine how we categorize and treat these diseases. Always consult with healthcare professionals for personalized advice, as leukemia classification is a complex but vital part of managing this condition.